Dear friends, I am going to talk about endoscopic endonasal trans-sphenoid surgery for pituitary lesions. Endonasal trans-sphenoid surgery is performed through the nose and the sphenoid sinus to remove pituitary lesion or other lesions in that particular location. This can be done with the help of endoscope, microscope, or both. The advantage and limitations of these two procedures, endonasal versus transcranial, are as follows. In endonasal approach, normal pituitary can be preserved. There is no manipulation of the normal brain or the vessels. There is better visualization, better resection rate, especially when the lesion is large. When the lesion is small within the cella, microscopic or endoscopic are the same, but when lesion is large, then endoscopic uh, is better because the visualization will be good. But there are limitations when there's little extension, brain invasion with edema, firm tumor consistency, involvement or vasospasm of the artery of circle of Willis, kissing carotid, encasement of optic apparatus or invasion of the optic foramen, poor general condition, infection or sinusitis, especially active infection, conchal type of cella is relative contraindication, and if the surgeon is not confident in endonasal approach, or when the facilities for navigation, Doppler, etc., are not present, especially when there's a complex lesion, resurgery, difficult lesion. In those cases, these facilities are required. On the other hand, the limitations of endonasal approaches are becomes the advantage of transcranial, such as if there's little extension, you can deal better brain invasion with edema, firm tumor consistency, involvement of the vessel or the nerve. You can dissect it better, except when the optic nerve is involved inferiorly. The greatest disadvantage of transcranial surgery is that in most cases, pituitary gland is draped over the diaphragmatic cella. So when you go transcranially, you first come across the normal pituitary gland. So there are higher chances of producing pituitary dysfunctions. In the workup of such cases, a detailed preoperative CT and MRI both should be done to provide anatomical information about the bone, soft tissue, and paranasal sinuses. Nasal septum deviation should be seen, and special attention with whether there is any spur or not, which may hinder the surgery from that particular side. Paranasal sinus anatomy should be very well studied with special attention to the sphenoid sinus. We should see whether the sphenoid sinus is prominent or it is flat. What about the pneumatization? Good, and which type of pneumatization is there, whether it is cellular, precellular, or conchal type, and if there is any dehiscent bone wall over the optic nerve or the carotid, whether the sphenoid septals are attached to the optic nerve or the carotid canal. All these information should be known, and if there are any complex septations within the sphenoid sinus, sometimes there are too many septas, including vertical and horizontal septas. There may be double flooring, there may be owner decel, and all these things may lead into incomplete cellular opening. So study the sphenoid sinus very well. You should also see whether there is any cavernous sinus invasion, and if it is there, then what type, the characteristics of the tumor, whether it is firm or soft, or where is the position of the carotid artery, and the optic pathways, including chiasma. What is the position of the normal gland? It is very important. Where is the gland displaced, superiorly to the left or right or anterior posterior? So the normal pituitary position, if you know preoperatively, then you can save these normal pituitary and the hormonal dysfunctions post-operative. These are some of the examples. This is the deviated nasal septum on this side. On axial and the coronal cut, you can find out the deviation, plus you can see the spur. In this case, the nasal septum spur is there on this side, which is also confirmed on endoscopy. So on the left side, this spur is going, so it will make surgery difficult when you work on the left side. These are the examples of the various pneumatization and the type of sphenoid sinus. There may be prominent sella, or there may be flat sella. In prominent sella, all the projections are nicely seen, so you can identify the anatomy very well, and the various projections such as carotid prominence, optic prominence, clival recess, etc., can be nicely seen. So there is hardly any need for any navigation. Whereas on the other hand, the flat type of the sella, all these projections are not seen. So this is the flat sella, this is prominent sella. So here it is difficult to find out the normal anatomy and the various structure underneath these bone. And therefore, if you have help of navigation, it is extremely useful in such cases. There may be a dehiscent carotid canal, as seen in this diagram on the left side. There may be bilateral dehiscent of both the optic canal, as seen here. Here, the sphenoid septas are getting attached onto the optic nerve, and this diagram, the septa is getting attached onto the carotid canal. So if you try to avulse the septa, then there may be injury to the optic nerve, or the carotid injury can occur. These are the examples of complex septations, multiple septas, the vertical septas and horizontal septas. So if these are there, then one may do incomplete opening of the cellular floor, and thereby there may be incomplete excision of the tumor. You should also know the Onodi cell, which is nothing but the posterior ethmoidal cell, which are extending in the sphenoid sinus. It can abut around the optic nerve, can cause incomplete sphenoidectomy, and you may find double flooring in such cases. If the lateral recess is greatly pneumatized, then it can separate the median nerve and the maxillary nerve. Usually these are by side, but when there's extensive pneumatization, the maxillary nerve can be separated far away. And in such cases, if there is a leak from the well pneumatized lateral recess of the sphenoid sinus, then you have to take a different approach, and you have to open the maxillary sinus, and the base of pterygoid also need to be drilled to access the lateral recess and do surgery. Kissing carotid is another limitations of trans-sphenoid surgery, because there is hardly any distance between two carotid artery. So in such cases, one should take transcranial approach. Identify the location of the normal gland and the pituitary chiasm as shown in this photograph. The position of the optic chiasm, normal gland, which takes up contrast more than the tumor. And normally the normal pituitary gland can be displaced anteriorly, posteriorly, or on the left or right. And in most cases it is draped over the diaphragmatic cellar. So there is thin rim of normal tissue usually present on the diaphragmatic sella, and therefore in trans-sphenoid approach is better because when you go transcranially, you first come across the normal pituitary gland. The cavernous invasion also should be noticed before surgery. Various grades are there. Then there may be subarachnoid extension of the tumor. There may be multiple nibbings which suggests subarachnoid spread of the tumor. If that is there, then we need to open the dura anterior to the diaphragmatic celli attachment and then try to push these subarachnoid extension into the tumor cavity and take it out. We should also be aware challenges of giant pituitary adenomas when the diameter of the pituitary tumor is more than 4 centimeter, or it is multi-compartmental, or it is extending up to the floor of the third ventricle. A word about the blood supply of the gland. The blood supply comes from the center and then goes to the periphery. So if you need to remove a pituitary gland blindly, when you don't come across any microadenoma during surgery and you want to excise the gland, in that case it is better to excise the lateral third first. So make a nick in the lateral portion and try to see whether there is adenoma in it or not, and then go on to the medial side, rather than if you make a cut in the midline, then you transect the blood supply and there will be hormonal deficit. The word about fibrous tumor, usually most of the pituitary tumors are soft, but in about 10% cases, these are fibrous, which are difficult to remove. So how to identify hypo or iso-intense on T2 weighted image? If it is there and if it is homogeneously enhancing adenomas, they are more likely to be found as compared to mosaic. MR elastography has been shown to be of more value to find out whether how much firm is the tumor. If it is firm tumor, then it is better to go for extracapsular excision. Initially, you may decompress using CUSA, make the tumor size small, and then go in between the capsule and the normal gland and take out the tumor. So the indication of surgeries are most pituitary tumors, whether these are functional or non-functional, which are compressing onto the optic pathway, causing hormonal dysfunction, is the indication for surgery. The exception is prolactinoma. Most of them can be treated without surgery. Most craniopharyngoma except pure intraventricular craniopharyngoma and those with lateral extension, lateral to the neurovascular bundles, are difficult to approach transnasally. So one can take transcranial approach in such cases when the extension is laterally and multi-compartmental. Rathke cyst also is another indication for such surgery. Regarding the procedure, surgeon stands on the right side of the patient and the assistant on the cranial side with the monitor in front. The nurses with the instrument trolley on the right side of the patient and another assistant and anesthesiologist on the opposite side of the table, as shown here. Regarding the head position, a neutral position is usually suffice for most suprasellar regions, but if there's more of anterior fossa extension, then you can take the neck extension, and neck flexion should be used when there's a more posterior fossa extension of the tumor. The patient is in supine with the head elevated and head is turned towards the left side shoulder, and it is rotated towards the surgeon so that you can visualize both the nasal cavity very well. The scope holder, if it is required, then it should be attached on the left side of the table. Endotracheal tube should be on the left side. The position of the table, your elbow should be at the level of the nose so that you can see nostrils very well and there is no discomfort during surgery. One or two instruments on either side of the endoscope to retract the nasal wall and expand the nasal cavity as shown here. Two instruments expanding the nasal cavity, and this is the endoscope. The stabilized scope at the nasal tip with gentle cranial push. This also increase the working space in the nasal cavity. Endoscope should be placed either at 12 o'clock position or 6 o'clock position near the septum, nasal septum, for symmetrical visualization and orientation of the midline. If you keep it too much away from the nasal septum, then it gives false impression about the distance from the midline. The epinephrine solution soaked patties are used to induce vasoconstriction of the whole nasal mucosa, and the sufficient time should be spent. You should also identify the normal structure. This is the septum, this is the middle turbinate, these are the patties which are placed in between the middle turbinate and the septum to lateralize the middle turbinate. Spending time for vasoconstriction gives better results. Otherwise, there may be constant oozing. After putting the adrenaline soaked patty, one should do some other work so that sufficient time is spent for vasoconstriction. Like you can take fat from the abdomen or from the thigh, or can take facial atta from there. And if you are doing a live surgery, then you can start explaining the radiology and the instruments can be discussed in between. Then you should thoroughly inspect both the nasal cavity to identify the normal structures and if there is any anatomical variations. So identify the turbinate, inferior turbinate, the middle turbinate. Inferior turbinate is most inferior, and the first turbinate which you come across in the nasal cavity most anteriorly, and middle turbinate as shown here, the choana and the nasal septum. All these structures on both sides should be inspected, and you should find out which cavity is more wider. Again, deeper view. This is the nasal septum, this is the middle turbinate, the tail of the middle turbinate, which leads to the choana, and the structure in the choana, the Eustachian tube. This is the tail of the inferior turbinate, again going towards posteriorly, going towards the choana. Then you should also know the structures which are lateral to the middle turbinate. So the lateral wall of the nasal cavity, these are important when you go for the CSF leak surgery or the intraorbital lesion excision. So you should also be aware of the structures which are there the uncinate process from anterior to posterior. Posteriorly, you have the ethmoid bulla, lateral to the middle turbinate. So these structures you should know. Then identify the spheno-ethmoid recess and the ostium. So this is the space between the nasal septum and the middle turbinate. This is the spheno-ethmoid recess, and when you go up from the choana about 1 to 1.5 centimeter above, you will find the ostium, which is near the superior turbinate. So go in the spheno-ethmoid recess, and just by the lateral side of the nasal septum, you will find the ostium. If it is not being visualized, you can also create the ostium about 1 centimeter above the roof of the choana. You will enter into the sphenoid sinus. So this is the landmark, the ostium of the sphenoid sinus, which is present superior side of the sphenoid sinus. So inferior to this will be the sphenoid sinus. So sphenoid sinus will be somewhere here. So even if you make opening at 1 centimeter above the choana, you will reach into the sphenoid sinus, but don't go beyond 1.5 centimeter, because this side will be the anterior fossa. So this is the superior limit. Ostium is the superior limit of the sphenoid sinus. Do not do error on the more side, towards the superior side. You can enter in the sphenoid sinus at the ostium or little below the ostium. Regarding the nasoseptal flap, which may be indicated when we have the large lesion or when there's an intradural pathology. We should spare the septal olfactory strip, which is present in the upper portion and in the posterior portion of the nasal septum. So your superior cut which you give for nasoseptal flap should be about 1 centimeter below the roof of the nasal septum posteriorly. But anteriorly, when there is an anterior margin of the middle turbinate, at that place the olfactory fibers end, so then you can extend your incision at the top of the nasal septum. So posteriorly, where there are olfactory fibers, you should leave about 1 centimeter of the mucosa intact. You can remove the bone, so make a cut there, dissect the mucosa up, and if you want to have some space, that can be done. But don't take out this mucosa, don't take the cut up to the superiormost side. If you do that, then you will damage the olfactory fibers, and the patient will have a difficulty in olfaction. The various types of the flaps are there. The traditional flap, that means I have already discussed that the superior cut is given about 1 centimeter below the superior limit of the nasal septum because of the olfactory fibers. And once these olfactory fibers end at the anterior limit of the middle turbinate, then your cut can go at the most superior portion, and then you make an anterior cut which is at the junction of the mucosa and the skin margin. The inferior cut is at the lower margin of the septum with the junction of the floor and at the choana. So the superior cut is at the lower margin of the ostium, and the inferior cut is at the superior margin of the choana. Don't make cut in between. So don't cauterize this, because the Spheno-palatine artery comes from here, and which is the main blood vessel responsible for this flap. So various flaps are traditional, as I discussed, the superior cut, inferior cut, but there can be mini flap or the posterior flap. If the cut is given at the anterior portion of the middle turbinate on the septum, so only the posterior half of the nasal septum is taken. So that is the mini flap, which is usually enough in most of the pituitary surgery. If it is required, then there may be larger flap. This can be done when you extend the inferior cut in the floor of the nasal cavity. So rather than having a mucosa of the nasal septum, you can also take the mucosa of the floor of the nasal cavity, and there can be rescue flap and the reverse flap, which I'll discuss later on. So I told you that the most important artery is the Spheno-palatine artery, which is the main blood supply of this flap, which should be preserved. So the superior cut should be extending at the lower margin of the ostium of the sphenoid sinus, and the inferior cut should be over the choana, I mean the superior margin of the choana. So preserve the Spheno-palatine artery. If you damage this, then your flap may become necrosed. So what is a rescue flap? Rescue flap is when you make only the superior cut. So you make superior cut, mobilize the mucosa, and take out the bone and the mucosa of the, make an opening in the mucosa of the opposite side, so that you can have a binostril approach. So you can introduce the instrument. The advantage of rescue flap is that if the flap is not required, if there is no CSF leak, then you can reposition the flap back, because only one cut has been given. Okay, and the mucosa has been mobilized. Intraoperative CSF, sometimes CSF leak is not expected, but it may encounter suddenly during surgery. So if you have made a provision for rescue flap, in that I have already told that only superior cut is made, and then you can, if required, you can fully harvest, because one cut has been made, so you can make another cut inferior and the anterior cut, and can take the flap when it is desired. If it is not desired, I mean there has been no leak, then you can reposition the mucosa, and the morbidity of the mucosa resection can be avoided. So traditional flap I have discussed, and the posterior flap. Only the posterior mucosa is removed. That otherwise is also required to make the binostril approach. So in most cases, you don't require that much large flap. So only posterior mini flap is sufficient to cover the defect. So how much long incision you have to make on the nasal cavity? Whether only mini flap is sufficient, or you have to take the traditional flap. So that depends upon the distance from the sphenoid ostium to the most posterior part of the tumor. So measure the distance, whatever distance is there, then your flap should be slightly longer, 1 centimeter, 1.5 centimeter longer than the distance of the sphenoid ostium to the posterior margin of the tumor, So that much of the long flap is required. So plan accordingly. So what about the age and the flap? Any patient who is more than 14 years of age, the nasoseptal flap is reliable, but in between 10 to 13, careful consideration should be made on the individual basis. Less than 10 years of age, usually this may not be enough, especially if the dural defect is large. So in such case, you can take bilateral nasoseptal flap, or you can extend flap in the nasal floor. So the width can be increased, but the length obviously will be short. So in the procedure, middle turbinectomy can be performed, especially if you have extended, you plan extended approach because you need more space. So on one side, uh, there should be middle turbinectomy is performed. On the opposite side, you displace the middle turbinate laterally. At times, the bulla ethmoid may be very prominent, so that does not allow the lateral displacement. So you can either just puncture the bulla ethmoid, the air will come out, and in that case, you can do better displacement, or you can partly remove the bulla ethmoid if it is too much pneumatized. If you have a smaller lesion, some people also do lateralization of both the middle turbinate, but I prefer partial turbinectomy of the one side and lateral displacement of the other side middle turbinate when the lesion is large and we require extended approach. The sphenoid ostium is identified again, and then you enlarge it inferiorly using Carrison punch, or you can use drill after lateralization or mobilization of mucosa over the anterior face of the sphenoid sinus. The sphenoid rostrum and the posterior vomer is removed so that you open the anterior wall of the sphenoid sinus fully. The word about how to introduce instrument from the other side, especially when you are using the endoscope holder and you have stationed the endoscope in one nostril. So how to introduce instrument from the other nostrils? So the trick is that the instrument should be parallel to the endoscope, and these should be parallel to nasal septum. So just lateral and parallel to the nasal septum, and do not use any force. Let the instrument go freely. If there is any resistance, then you can little bit manipulate it cranial caudal or medial lateral. But if you keep it parallel, then it usually goes without causing any damage to the nasal mucosa. The other trick is the instrument which are passed through the opposite side of the nostril, means the opposite side from the endoscope. So you keep that instrument in the cavity itself. Do not take out it too frequently. So use it, and then when you don't use it, just put it inferiorly there and leave that instrument rather than removing and introducing it too frequently. But if the assistant is holding a scope for you, in that case, you can remove your endoscope and insert the instrument under vision of the endoscope to avoid damage to the nasal cavity. The posterior ethmoidectomy is done on one side, or if required, also on the opposite side. So unless the posterior ethmoid is removed, so this is the sphenoid sinus, This is the posterior ethmoid. So unless you remove this, you will not be able to see the anterior and anterior portion, the sphenoid sinus, anterior and lateral. And this diagram also shows that if there is well pneumatized lateral recess, then removal of the anterior wall of the sphenoid sinus is not enough. In this diagram, you can see that you should to go here, you have to remove the medial wall of the maxillary sinus, the posterior wall of the maxillary sinus, and the spheno-palatine foramen structures you have to mobilize. Only then you will be able to visualize these structures. And this is required when there is a CSF rhinorrhea which is coming through the lateral recess of the sphenoid. So this anatomical knowledge is very important. So identify all structures in the cellar floor after removal of the anterior wall of the sphenoid sinus. You should be able to see all these prominences. The prominences of the optic nerve, the prominences of the carotid, and the recess in between. So the lateral recess in between the optic nerve and the carotid is the lateral opticocarotid recess, the medial opticocarotid recess, and then there is a cellar floor, clival recess, and this is the carotid artery in the cavernous portion. In the clival portion, laterally, you will find the prominence, and that is the clival portion of the carotid artery. So that also, that this prominence should be visualized, and this also helps in finding out the midline. So find out both the clival carotid artery, and the middle of these two carotid artery will be the midline. So identify the various lateral opticocarotid recess, medial carotid protuberance. I have already discussed optic protuberance, the tuberculum celli, the planum sphenoid, and after removal of bone, you will find these structures. There are some constant midline markers. Base of the vomer, as shown here by the arrow. So these are always in the midline. So base of the vomer or the rostrum. Rostrum is also, sphenoid rostrum is also in the midline. And I have also discussed that the clival carotid. So identify both the clival carotid on either side, and the middle of these will be the midline. But don't rely on the septa. Septas are, sphenoid septas are always, usually these are eccentric and they are not in the midline. So one can visualize the structure as shown after the removal of the both or one posterior ethmoid, the septum, posterior septum removal, and the cellar floor removal. For blues, you should be able to find out after bone removal, cavernous sinus on either side, anterior intercavernous sinus, and the posterior intercavernous. So all four blues, this much bone you should remove for pituitary lesions usually. You might have to extend bone removal anteriorly or posteriorly or even laterally in the extended approach, which we'll not discuss in this particular lecture. About the dural opening, you should make a cut in the inferior half of the dura and leave the superior portion or anterior portion intact to prevent premature descent of arachnoid. So you can make a T-shaped incision or a horizontal incision and two downward incision, and take out the tumor from posterior side and from the lateral side first, and the superior side of the tumor should be removed in the last, because if you remove this first or in between, then the arachnoid may descend, and the tumor removal in the rest of the portion may become difficult. You should try to find out the cleavage between the tumor, which is surrounded by the pseudocapsule, which is nothing but a compressed normal gland. So in between the pseudocapsule and the normal gland, you should create a cleavage. Also do pituitary transposition. If the lesion is going posteriorly towards the posterior cranial fossa, but if you require this transposition, then do it unilaterally. If you do it bilaterally, then all blood supply to the pituitary gland goes, and there is invariably, in all cases, you will come across the pituitary dysfunctions. In most cases, the tumor creates a space for you and you don't require anything. So just take the help of the tumor cavity and you can go posteriorly. But if it is required, then open it from one side only. So cut periosteal layer of the covering and leave meningeal layer, and then cut those ligaments which are there extending between the pituitary gland and the lateral wall. And also you can sacrifice inferior hypophyseal artery. The arachnoid should descend uniformly. But if you find that there are multiple lobulations, the arachnoid is not descending uniformly, that means there is some residual tumor, and in such case you have to open the neck of these lobulations. You should be able to identify the normal gland by its form and pinkish appearance, and there are longitudinal vessels on this, and usually these are plastered on the diaphragmatically. This is a short video of pituitary macroadenoma. You can see the normal gland superiorly displaced, also anteriorly, and this is the post-operative CT scan showing complete excision of the tumor using endoscope. So initially, the middle turbinate is being resected after coagulation of the superior attachment and the posterior attachment. This is the nasal septum. Nasoseptal flap being raised and making a superior cut and the inferior cut. This is the mobilization of the nasoseptal flap, and then a removal of bone and making it by nostril approach. This is removal of the anterior face of the sphenoid sinus, bone being removed, and now the drilling of the cellular floor, including the plenum superiorly, because this patient had a large supracellular extension. So I have discussed that if there's a large supracellular extension, you have to extend your bony opening on the tuberculum celli also, and part of the plenum need to be required depending upon the size of this. This is the dura being opened. The superior portion of the dura is left intact so that it prevents when premature descent of arachnoid. First, the posterior portion of the tumor, and then the lateral portion of the tumor is removed using bimanual technique. And now you can see that after tumor excision from all around, the arachnoid is descending, and there is some pinkish normal gland is seen over the arachnoid. And after achieving a good hemostasis, one should place little bit of fat so that empty seller syndrome can be avoided. And then the vascularized flap has been put and then stabilized with the fibrin glue. There are two types of excision of the tumor, extracapsular excision and intracapsular excision. Basically, capsule is a pseudo capsule. It is not a true capsule. So it's a normal compressed gland. In extracapsular excision, it should be done in functional lesions, functional tumors, microadenomas, fibrous tumors, but there is a more risk of endocrine deficiency, especially if the patient is already having hypopituitarism, because you tend to remove little bit of more normal gland along with the pseudocapsule, which is again the compressed normal gland. But the chances of excision of the tumor are more, so it's good for functional and microadenoma. Intracapsular excision is performed when there's a large lesion, so go for internal decompression, non-functional tumor, invasive tumors, and especially if the patient is already having hyperpituitarism. So try and keep the pseudocapsule intact, because that is also a normal pituitary gland. High tumor resection rate and high and sustained endocrine remission rate can be obtained when you go for extracapsular excision in non-invasive functional tumor. So the special indications of individual type of excision is required, not that in every case you go for only extracapsular or intracapsular, or one can go for both intracapsular and extra. Initially you can go for internal decompression, and then and when the tumor has become small, then you can go all around and do extracapsular excision of the lesion. Regarding the CSF leak and its repair, there are various techniques: overlay, underlay, combined obliteration technique. This overlay and underlay are in relation to the bone and not in relation to the dura. So the overlay is when the graft is placed outside the bone. Underlay is when it is in between the dura and the bone. You can also use graft intradurally or subdurally, or one can take the combined multilayer technique. You can put it tissue intradurally when there's a large cavity left after tumor excision. So put in fat to obliterate that cavity, and then you can have inlay, outlay technique, and multi-layer closure can be done. The meta-analysis shows that both techniques, overlay or inlay techniques, have resulted into similar results of CSF repair. This is the multi-layer technique in which the fat, you can use facial atta or the artificial duragen, and then fat, and then you can also support, if the dural defect is large, you can support it with the cartilage or the part of the bone, and then you can have a vascularized nasoseptal flap. So multi-layer closure is always better. The Surgicel should be placed at the margin of the graft or the flap, so that it does not migrate, and then you should support these graft or flap by balloon or marrow seal so that it does not displace while coughing or sneezing or straining after the surgery. Um, when there's a high flow leak, and especially when the ventricle has been opened, then you should use multi-layer technique, including gasket seal technique. So in that, the bone piece is put inside and it works like a gasket. And for detail, you can refer to chapter 6 in my book, The Neuroendoscopic Surgery, a Comprehensive Approach. In the closure, when it is pre-chiasmal defect, then you can put in a small fat or large fat depending upon the space created. So putting in a fat there in pre-chiasmal defect is not an issue, but if there's a post-chiasmal defect and if the ventricle has been opened, then one should avoid putting in small fat packing because it may go inside the ventricle and produce hydrocephalus. Balloon, when it is used, it should be outside the anti-wall of the sphenoid face. Do not inflate the balloon in the sphenoid sinus. It can cause compression on the nerve or on the vessel. The obliteration technique, when you obliterate the whole space using fat, that is also quite effective. But in these cases, all mucosa should be removed, otherwise there may be mucocele. Fibrin glue, when you use, should not be put in between the layer. When you are going for multi-layer closure, then do not put one layer and then glue and another layer and glue. So what you do is that you can put little bit of glue at the margin of those layers, but not in between the two layers. It has been seen in the studies that if you put in glue in between the layer, it prevents fibrosis, and ultimate healing by fibrosis is required, which is being prevented by putting in glue in between layers. So regarding the age, the pyriform aperture is small in the children under 2 years of age, and the sphenoid sinus also pneumatization starts at 2 years of age and it completes at 10 years. And the septum also, so sphenoid sinus and septum both are less developed under the age of 10. But the intercarotid distance remains same even at any age, even at birth. So this diagram also shows that if there is large supracellular extension, then you need to remove the tuberculum celli and the part of the plenum sphenoid. Otherwise, the anterior and the superior portion, supracellular portion of these tumor is difficult to remove, especially if it is fibrous and it does not fall. So you need to remove bone, and then you need not to open the dura. You just, with the suction or any micro instrument, you can push the dura superiorly and take out the tumor which is present superiorly or anteriorly. Regarding the results of endoscopic surgery, it is effective and safe. The results for a smaller lesion, especially when there is only tumor within the cella, then microsurgery and endoscopy equally are good. But when the lesion are large and there is a superior extension and little lateral extension, endoscopy is better because it provides better visualization. So tumor resection rate of large lesions using endoscope is better, and the results of endoscopic surgery over microsurgeries are better in terms of hormonal control, and also the extent of tumor resection is better. The visual outcome is also better when you use endoscope, especially when the lesion is large. But the complications of microsurgery and the endoscopic surgery in large studies, including meta-analysis, are the same. So this is one preoperative imaging and the post-operative imaging showing complete tumor excision. So to summarize, detailed preoperative CT scan and MRI scan study is important to know the anatomical information about the type, the sphenoid sinus, the whether it is prominent or flat, the sphenoid sinus with special attention to the dehiscent wall of the optic canal and the carotid, the sphenoid septa attached to the optic nerve or the carotid canal, the complex septations, double flooring, cavernous sinus invasion, the characteristic of the tumor, whether it is soft or firm, the position of the carotid artery, the optic pathways, and the position of the normal gland infundibulum. The results of endoscopy and microscopic surgery using trans-sphenoid approach is same for a small lesion, but endoscopy is better when there's a large lesion with superior and lateral extension. It provides better hormonal and vision results and superior tumor excision rate. The complications are same of microsurgery and endoscopic surgery. The vascularized nasoseptal flap has reduced CSF leak rate, especially when you are dealing with the intradural lesions. Thank you very much.